Hello, welcome, and thank you so much for joining us for the Transplant Symposium this year. In this lecture, we are going to discuss the pre-transplant mortality rate ratio. This is a new OPTN performance metric for transplant centers. My name is Kristen Coe. I am a nurse practitioner and clinical transplant coordinator at UC Irvine Health. I have no financial disclosures. The objectives for today are to discuss background regulatory changes that led to the development and implementation of the pre-transplant mortality rate ratio, discuss the purpose of this new metric, define it, review the SRTR reporting and methodology for the calculation of this ratio, and we will also identify the MPSC criteria for performance review for transplant programs. And finally, we'll explore implications for transplant centers and care partners. First, let's discuss some background information to provide some context for this new OPTN metric. For those of you that don't already know, transplant is a heavily regulated field. Programs are regularly evaluated on their performance to identify potential risks to health or public safety. The OPTN, which is the Organ Procurement and Transplantation Network, has a membership and professional standards committee, which is called the MPSC. They regularly evaluate transplant program performance. In the past, they did this by evaluating 1 year post-transplant graft survival, as well as 1 year patient survival. However, as you can see on this graphic of the transplant continuum, the metrics for 1 year post-transplant graft survival and 1 year patient survival only focused on evaluating transplant programs in accordance with post-transplant outcomes. In recent years, the MPSC recognized this, as well as the need to incorporate metrics that evaluate multiple phases of transplant in order to create a more holistic approach to the evaluation of transplant program performance. They also wanted to develop a performance review system that would provide maximum support for the OPTN strategic plan, which includes increasing the number of transplants, promoting equitable access to transplant, as well as fostering innovation in transplant. Therefore, in December 2021, the OPTN Board of Directors approved bylaw changes that establish 4 new monitoring measures aimed at waitlisted patient care, offer acceptance practices, perioperative care, as well as postoperative care. These 4 new risk-adjusted metrics were rolled out over the past several years, and they each address a different part of the patient journey. For perioperative care, we have the 90-day graft survival. For postoperative care, we now have the conditional 1-year graft survival. For offer acceptance practices, we have the offer acceptance ratio, and for waitlisted patient care, we now have the pre-transplant mortality ratio. In today's discussion, we will focus on one of these 4 metrics, the pre-transplant mortality ratio. This metric was developed with keeping in mind that a patient's goal is to gain access to transplant, not just a waiting list. Therefore, the new OPTN metric aims to increase the likelihood that a patient makes it to transplant by encouraging improved waitlist management and incentivizing transplant programs to have more aggressive offer acceptance practices. The pre-transplant mortality rate ratio is now used to evaluate a program's pre-transplant mortality rate relative to the mortality rate experienced by similar patients across the nation. This metric indicates whether patients listed at a transplant program are more or less likely to die prior to receiving a transplant than expected. And as you can see in the graphic, this metric focuses on waitlist patient care, and that's from the time of listing until the patient is transplanted or removed from the list. It does not consider the pre-transplant evaluation period that occurs prior to listing. In order to understand how the pre-transplant mortality rate ratio is used in transplant program performance reviews, it is first important to understand how it is reported and the methodology behind its calculation. The pre-transplant mortality rate ratio is reported through the Scientific Registry of Transplant Recipients, which is the SRTR, Transplant Program Specific Reports. This metric was officially implemented on July 25, 2024, and it is risk adjusted to account for program-specific characteristics of transplant candidates, recipients, and donors. Before diving into the details of pre-transplant mortality rate ratio calculations, I would like to acknowledge that much of the information for this talk was derived from SRTR resources, including this linked presentation on waitlist mortality. The figures and SRTR information on subsequent slides were derived from this presentation, and if you are interested in this topic, I would highly encourage you to view this SRTR presentation as well. With that, let's dive into the details on how pre-transplant mortality rate ratios are calculated. Waitlist mortality rate ratios are reported through the SRTR program-specific reports. These reports are available online at srtr.org. They're published every 6 months and contain data for a 24-month or 2-year observation period. The reports include information on waitlist registrations, observed and expected waiting list mortality rates, as well as the waitlist mortality rate ratio estimate. The reports also compare transplant center performance to the OPO, region, and US. In this example of an SRTR report, we can see that the observation period was from July 1st, 2017 until June 30th, 2019. The count on waiting list at start represents the number of patients on the list at the beginning of the observation period. The person years is calculated by adding together all the time candidates spent on the waitlist during the observation period. We'll discuss how the person years is calculated in subsequent slides. And the number of deaths represents the actually observed number of deaths during the observation period. Person years is an important value used in the calculation of the pre-transplant mortality rate ratio. Person years is used to represent the amount of time transplant candidates were on a specific transplant program's waitlist during the 2-year evaluation window. As we know, some candidates may be on a waitlist for the entirety of the 2-year evaluation period, whereas others may be on the waitlist for just part of that period. Person years is calculated by taking the sum of the number of days each candidate was observed for a specific transplant program during the evaluation period and dividing it by 365.25. Included in this calculation are any candidates that were listed during the 24-month observation period, any candidate that was alive and listed for at least 1 day during the 24-month observation period, any candidate that was already on the list at the beginning of the observation period, as well as all active and inactive candidate time. So to be clear, there is no difference whether a patient was active or inactive. All of that time will be used in the determination of the person years value. It is also important to note that candidate time is no longer counted towards person years if a candidate is removed for death, transplant, or recovery. So if a patient passes away, the time after their death is not counted. If the patient is removed for recovery, so for example, if their kidney regains function, that patient is followed for a maximum of 60 days. However, it is important to note that deaths during this time will still count towards the mortality rate ratio if it's within the observation period. No time after transplant is counted, as this is counted in the post-transplant cohort. If a patient is delisted or removed from the waiting list, the time also stops being counted, but the candidate will still be followed until the end of the 2-year observation period. If a patient transfers to another transplant center, the person years calculation time ends at the date of the transfer. In this graphic from the SRTR, you can see that even if a patient is removed during the 2-year evaluation window, they continue to be followed for events until the end of the observation period. Since we are talking about a new metric aimed at pre-transplant mortality rates, it is important to understand how deaths are calculated for the ratio. In the SRTR report, deaths represents the number of deaths that actually occurred during the observation period. It's also important to understand that deaths that occur after removal from the wait list, but prior to the end of the observation period, are counted toward the mortality rate ratio. Deaths that occur after removal for recovery, but are still within the 60-day follow-up period after removal, are counted towards the mortality rate ratio as well. Therefore, since SRTR reporting cycles are every 6 months, deaths may show up on multiple reporting periods. In this SRTR illustration, you can see that since the evaluation period is 2 years, but the reporting cycles are every 6 months, it is possible that a death that occurs may show up on multiple SRTR reports. Now that we have a better understanding of how the SRTR derives values for deaths and person years for each program, we can discuss the observed and expected waitlist mortality rates. In this graphic, you can see the observed events are events that are actually observed during the observation period. So that means the number of deaths that actually occurred for a program during the observation period. Expected values are derived from waitlist mortality models based on national data and applying the models to the specific data for a transplant program. We will discuss this in subsequent slides. To calculate the observed mortality rate for a transplant program, the SRTR takes the observed deaths for the program divided by the person years and multiplies it by 100. To determine the expected mortality rate for the program, they take the expected deaths, which is derived from the waitlist mortality models, divide by the person years, and multiply by 100. It is important to note that the SRTR uses separate criteria for adult and pediatric candidates. To calculate for expected values for each transplant program, the SRTR attempts to adjust for each program's respective risk level by taking into account program-specific characteristics of transplant candidates, recipients, and donors. This is done in order to have a fair and accurate performance monitoring system. It allows the MPSC to focus on elements of patient care that are within control of the program, and it's also used to avoid risk-adherent behavior that would result in unintended negative consequences, such as organ discards or a decrease in organ transplants. The risk adjustment models are quite extensive, and they are available on the SRTR website, and they're based on the mortality of patients with similar characteristics and length of time on the wait list across the nation. Now that we've discussed how observed and expected mortality rates are determined for a transplant program, we can discuss how the pre-transplant mortality rate ratio is calculated. The pre-transplant mortality rate ratio is reported as an estimated hazard ratio, and it is calculated by taking the observed mortality rate plus 2 divided by the expected mortality rate plus 2. In this graphic, you can see that for this transplant center, the estimated mortality rate ratio was 0.48. This value shows how far off or how close to expected a program performed during the observation period. 1.0 indicates that a program's performance is average. Less than 1 indicates that a program is performing better than average, and greater than 1 indicates that a program is performing worse than average. So at what point should a transplant program be concerned about their pre-transplant mortality rate ratio? Every 6 months, the SRTR will publish this information, and the MPSC will review a transplant center's performance if the pre-transplant mortality rate ratio is greater than 1.75 during the 2-year period. Of note, this value is the same for adult and pediatric programs at this time. If a transplant center is flagged for performance review by the MPSC, it must participate in that review. This review may require that the transplant program take appropriate actions to determine if the program has demonstrated sustainable improvement. If the MPSC's review of a program determines that a risk to patient or public safety exists, they may request that a member inactivate or withdraw a designated transplant program or a specific component of the program to mitigate the risk. Now that we've discussed the pre-transplant mortality rate ratio at length, I thought it was important in the last few minutes of this presentation to discuss practices for transplant programs as well as care partners to help improve pre-transplant outcomes. For transplant programs, it's important that they have robust waitlist management and involve the multidisciplinary team in the reevaluation and optimization of waitlist candidates. It's also important for transplant programs to utilize technology, such as the OPTN computer system tools, EHR checklists, in order to optimize waitlist practices and maintain the waitlist patients. Transplant programs should also have robust and standardized offer acceptance practices to optimize offer acceptance processes. Programs should also identify patients who are more likely to receive an offer in order to keep them ready for transplant. Programs may also consider creating hot lists to prevent turndowns and ensure patient readiness should an organ become available. Programs should have standardized evaluation protocols and focus on the optimization of candidate selection for listing. By this, it means that they should standardize and adhere to listing criteria and revisit the listing criteria with the multidisciplinary team on a regular basis. Transplant programs may also consider conducting morbidity and mortality reviews for pre-transplant mortality events, and they should review and update pre-transplant data, policies, and protocols on a regular basis. It's also very important that transplant programs have consistent and standardized communication amongst its team members. For example, team huddles, physical proximity, messaging through third-party platforms, or the electronic health record are all great ways to maintain communication. Similarly, transplant programs should ensure that they're maintaining effective and regular communication with the patients as well as care partners. And lastly, it's important for transplant programs to ensure sound quality practices as well as data analytics. There are also multiple ways in which the care partners can help to improve pre-transplant outcomes. First, it's important for care partners to communicate changes in patient condition to the transplant center. This includes changes in their medical status, such as cardiac or respiratory issues, new diagnoses of cancer, or any other major medical condition. This may also pertain to the patient's psychosocial status, so changes in the patient's caregivers or ability to be successful with a transplant or follow-up. This also refers to changes in the patient's financial status. So if you become aware that a patient has changed their insurance, it's very important to communicate to the transplant center. It's also important that care partners report patient deaths to the transplant center in a timely manner so that the transplant center can remove the patient from the wait list and report it to SRTR. It's also crucial that care partners work with the transplant center and start patient education and establish patient expectations for the transplant process early on. As we all know, some wait lists can be very long, and care partners are crucial in ensuring that patients stay educated and informed as to the transplant process. It's also important for care partners to understand that transplant centers are not just being evaluated by post-transplant outcomes anymore, but they are being evaluated by the pre-transplant mortality rate ratio, which encourages transplant programs to maintain wait lists with suitable candidates at all times. And with that, I'd like to thank you for your attentiveness and participation in this year's UCI Kidney, Pancreas, Transplant, and Nephrology Symposium. I hope you learned a lot, and please feel free to go back and review these slides, as I know that this information can be a bit overwhelming the first time through, maybe even the first few times through. Please feel free to reach out to me by phone or email if you have any further questions. And I've also provided you here with a slide of additional resources, most of which are from the OPTN and SRTR, to help you better understand the new performance metrics, specifically in regards to waitlist mortality. So thank you again. Thank you for partnering in the care of our patients, and I wish you all the best. Take care.